was something that came up when I started thinking about. A lot of people ask me, how do we learn about this? How do we, will people share inside information on what it was like to run a company, the challenges, the ups, the downs? And I thought, well, if we look at it that way, then they have to be really nice, intimate discussions where people feel comfortable and forthright. And at the same time, let's provide a spectrum of that. So let's start from, all-star startup to, global connected healthcare device. So we're going to kick this off with Omada. I picked a stat for each of the companies that I chose, and I just thought it was really interesting. Their focus is on diabetes and diabetes prevention. So the average Omada participant may avoid $2,000 in projected medical spend over 5 years, and hopefully I have that stat correct. So I thought that was great. So I want to welcome them to the stage. Casper de Klerk is going to be doing the interview. He's the general partner at Norwest Venture Partners. You guys can come join me on stage. With over 30 years experience, Casper is a veteran of the medical device and life science industry and brings extensive operating knowledge to Norwest Venture Partners, where he focuses on mid to late stage investments in consumer and digital health, healthcare IT, medical devices and diagnostics, technology-enabled healthcare services, and specialty pharmaceuticals. I thought it was important to list out all the areas that you cover because I think people want to know.
The whole gamut, except biotech.
That's it. Enjoy.
Great. Well, I'm going to let Sean talk a little bit about the company, and I've known Sean, I think, probably 5 years since you started.
Yeah, it was. I think you were maybe the second VC I had ever met.
It's great. And I met his partner Adrian, who was at IDEO at the time, and have had a passion about diabetes ever since working in the drug delivery space probably 15 years ago. But why don't you describe, and I'll certainly talk a little bit about why I was attracted to Sean as an entrepreneur and his co-founder, as well as what was appealing about the company.
Oh, yeah, wonderful. So hi, everybody. Sean Duffy, co-founder and CEO of Omada. Really just, quickly on the problem that we're trying to solve and really the need for something like what we do to exist in the world. For the first time in global human history, preventable chronic disease is killing more people than infectious disease. So this is a new thing just for the globe. It's a crisis in the US, it's a crisis abroad. Most health economists, they look at, inflation of chronic disease costs, and they deem that as one of the key things that can cripple health economies, across the country. And in large part, it relates to obesity. And so Omada's built a program, called the Omada program that helps people at high risk of these chronic diseases like diabetes through a very kind of intricate, orchestrated, high-tech but high-touch approach. Helps them make modest amounts of lifestyle change that lead to weight loss, that lead to risk reduction of progression through the chronic disease continuum. Mm-hmm. The clinical basis for this is there's an extraordinary body of evidence that shows really what you can do for someone that's at the brink of chronic disease. Maybe they have pre-diabetes and they're heading toward diabetes. If you catch them at that point and you really drop in a very high touch program, the evidence shows that you can make a very meaningful impact in their health. Yet historically, it had been quite hard to translate that evidence to the digital era and put together what you need and all the ingredients that you need to do it scalably and efficiently and across the country, which you have to meet the need. So that's what we do.
So with all these wearables, and here we are at CES, and it's all technology. Why don't you just give everybody a fitness band and we're done?
So we I always call that the single instrument fallacy, where it's hard to get anybody to do anything. Clinically, getting any meaningful weight loss outcome is extraordinarily hard, just because it's a very tough emotional thing to go on that journey. And if you take the symphony analogy, if you're Beethoven and you're trying to write the Fifth, and you need it to be emotionally moving, and you want to do it with just the bassoonist, you're not going to be successful, right? You also can't just have all the instruments and not have them play on a score. And I kind of think that there are elements of that in the wearables world. All of the connected scales, trackers, all of those are incredible for creating programs around them, but each one on their own tends to not yield a result. And you actually see this in the data. I mean, you can't just send someone a scale and show them a chart of their weight. You can't just show them activity. You can't just get them a coach. You can't just put them in a group. You can't just give them curriculum. Each one of those things on their own tends to not work. I mean, there's been randomized controlled studies, looking at what happens when you prescribe a calorie tracker, and you see a null result because it's that one thing. So I think the way we've always viewed it from day one is if you can passively collect data from connected devices, but use it to create social experiences, contextual programs around it, then you can have success. But the data is table stakes. It's kind of the means to the program.
That's great. I think in my mind, at least, if you think about a very sophisticated athlete, triathlete, they're measuring themselves all the time. And what we forget, particularly in the Bay Area, is that we're all relatively healthy and athletic and outdoorsy, and to project from our own experience to patients that have chronic disease. And unfortunately, a lot of that's behavioral. The analogy, my equivalent analogy is the marshmallow story, right? The marshmallow experiment, where the child can get one marshmallow now, or 15 minutes from now they can get two. And I think healthcare, at least with chronic disease, is you can have one marshmallow now, or you can get two in 10 years. Which one of us would actually start doubling our workouts if we knew we were going to get heart disease or heart attack in 10 years? You're probably going to wait 5 years and then get started, or maybe 7 or 8. So I think this question of really getting motivated is a fundamental one. So I'd say the other analogy that we think about is sort of the seesaw of how much work is it to collect the data versus what I'm going to get out of it. Again, with the assumption that if it's a chronic disease, I've gotten to a place where I'm overweight, I'm not particularly motivated, things are just spiraling. Same thing with chronic obstructive pulmonary disease. I've been smoking for a long time. Congestive heart failure, same issue. So I think one of the fallacies that we see, we were early investors in a company called Misfit, Basis as well, which was the first kind of heart rate monitoring on your wrist. Early days, and as we've seen, it's gotten incredibly competitive. But the lesson from that was that people will wear a Fitbit for maybe 6 months, and then it's only 10% of them. And the first analogy, the first movement you can get is by socializing that environment. So if I connect to my friends, I think the data was like 5 friends or so, you'd have 20% of people still doing this. On the other hand, there's some very interesting new technologies like scales, I think, are minimally friction, minimal friction. Sleep is minimal friction, so putting something under your mattress. But sort of the wearable idea, got to be very thoughtful about what to do there. Maybe let's just talk a little bit about, your thoughts about why it needs to be so, because this was one of the concerns we had about investing in Omada originally, was this really intensive, sort of along that theme, this really intensive engagement.
Yeah, it's funny. I mean, I think of it in kind of a couple capacities. The program itself has to be neat. It's funny. I mean, you look at our design and engineering team. They stem from the consumer world, so it has to feel like something you might want to do or has value. Looks easy, looks interesting, kind of looks beautiful, looks like something I'm surprised I don't have to pay for this. Like it has to kind of carry that feel to pull people in. And then you have to consider marketing as part of the product too. I mean, I started Omada when I was in medical school, so we have a huge kind of medical team, but our enrollment team comes from the consumer world. Our enrollment lead led marketing for Google Fiber, and it's you don't reach out to people and say, like, in 2002 the New England Journal of Medicine published the national. You have to really articulate like what the person's going to get out of it, like in the near term, and then let the rest kind of work. And then we always talk about it as kind of a binary, like turning a complex decision into a binary choice, where you actually see this if you look at prediabetes specifically. There was a study that was put out that shows that 68% of people, when you tell them they have prediabetes, they actually try to lose weight. They go out and try to do something. They just never do it successfully. And anyone in this room can imagine why that is. Like, let's say you find this out. Oh my gosh, I have prediabetes. My doctor tells me to lose weight. You may be worried about that, but you leave and you might not be sure what diabetes is. You're like, I know that's high sugars. Do I stop eating sugar? They said to lose weight. How much weight do I lose? How do I lose weight? Do I have the support? So,
or does my family culture say I'm going to get it anyway?
Culture, exactly, and your brain just kind of locks up, and the most likely path is what the control arm of every study is, which is just heading toward it. So, if you can turn that into like, look, this is complex and it's going to be hard, but just binary. Sign up for the program or not. Like, we're here for you if you want it, and also it's really neat. you get more kind of uptake. And people describe that to us. I mean, we'll have participants say like, look, I signed up, it looked kind of neat, like I got the scale, it looked kind of, beautiful experience. And then all of a sudden I had a group around me, I had a coach, like I got the scale on Sunday, there was a timeline, like lessons would unlock, that my coach would say hi if I didn't do them. I was like, I guess I'll just do it. and because it's hard work, but you have to, glide people and just make it so simple to start.
Yeah. So I think one of the other challenges that we see on the Omada has been focused on employers to begin with, and now we'll talk a little bit about the sort of rollout more into the medical world. But very strong data suggesting, of course, that the incidence of people developing diabetes is reduced substantially. But how do you get people to sign up as employees, right? That's the other, it's sort of the enrollment, and then you've got people sticking to it because the recidivism is a big issue. But walk us through sort of what percentage of people actually make it through the program, people that lose the weight, and then how do you get them in, and what's the technique to get them even started? Because this is consumer marketing.
No,
right?
It is, yeah. I mean, on kind of the front end, this was a big, investment for us to build out enrollment capabilities, frankly, at Omada. And we have to do it because we have a performance-based pricing model.
Yeah.
We have to get people in and get them to health outcomes to make profits in the company. So it was a bit Darwinian early on, where we're signing contracts with 100,000 covered lives and then no guaranteed revenue. So you figure out how to get people in when you're in that situation. So we invested very heavily in this enrollment marketing team, and it's we staff it we have this enormous library of the different templates of assets we use for different scenarios.
Yeah.
Are there regional dynamics we can create with companies that have offices in different areas? We always try to lean toward email marketing and then getting clients comfortable with letting us do the marketing because it's so orchestrated into our marketing automation to pull people into the program. Because we'll get 3 to 4x the yield of enrollees if we do the marketing.
Yeah.
And bit by bit, it's really started to work. I mean, we work with Lowe's as a national benefit across the company, across the the country. And Bob from Lowe's, always kind of shares when he talks about Omada that this was the most viral program they've ever rolled out at Lowe's, and it's because the marketing. And then once you get people in, you can't be successful with everyone. We always give it our best try, but we'll get about 70% of people to graduate the program.
That's great. And you've also catching people that moment of truth, right? Because you got to get them to do the test, ideally.
Yeah. That's another kind of neat thing in this space. And we started with employers. Increasingly, we're being thought of as just a reimbursable benefit and working with more and more providers. We just announced something with the American Medical Association and Intermountain. But when you piggyback off that moment of awareness, it's great because there's this trend in the employer space where employers will sponsor biometric programs and they'll incentivize employees. They'll pay employees a couple $100 just to get the test, right? And you may get this result and you look at it and it's like you find out you have prediabetes, but there's nothing for you on the other side of that. So we love when we can take in those feeds, and we should have some exciting news to announce in a couple months on a way to really double down on that strategy and follow on a blood test with a program.
Yep. So I'd say one of the other themes that we look for as investors, and it comes a little bit from kind of what your tradition was. I come really out of the clinical world, the medical device world, and for as much as people don't like the FDA and the barriers it puts up, it's actually a very important validation, I would say, of clinical data and forcing people to do a randomized control trial and actually showing outcomes. And increasingly in the world of payers, you've got to show an ROI. My own kind of cynical view is that you need to have an ROI within a year to 2 years. Otherwise, people just don't forward invest. So the DPP program, I thought, was a fantastic, it was a massive study. You might want to talk about it just briefly. Massive study, and what Omada did was a very nice sort of bridging study to say, hey, we're equivalent to what the DPP trial did. I'd say the vast majority of digital health startups don't have nearly that amount of data. So you get a bunch of pilot programs started, but then in the end, the kind of, where's the beef? You can be in there for a year, but at some stage, the CFO of the company says, hey, nothing's happened here, or it's costing me a lot more. You see that a lot with telemedicine, where people are paying whatever it is, $2 per member per month. But if you look at it on a per call basis, it's probably $100 to $200 on a per call basis. But maybe just walk through kind of how the DPP program, how that's translating that now into, guidance documents and early days with HR people versus now going into insurance and providers.
Yeah, well, we're the space we're in is we're really blessed in that. We started the company. I remember reading PubMed, and in all of these epidemiological publications, the discussion section was like, "Oh my gosh, if only people could scale this program."
Yeah.
And so there was clearly a clinical pull, and since that moment, it's created these kind of tailwinds, not just for us, but the space at large to, roll out these programs. And that includes a lot of, both clinical validation data, not just the original trial that demonstrated what could happen here, but just, tons and tons of subsequent translational efforts to bring that early program into practice, but also great economic data. So, the most recent example is Medicare did a demonstration with about 8,000 Medicare enrollees, looked at the economics and saw about $2,000 in savings at 15 months. And so they've decided to make it a reimbursable benefit. And that's where I think these programs are going. And I think digital health, generally can get there where historically, if you wanted to commercialize something that got a healthcare outcome, it would be most likely like a molecule, protein therapy, a device, and it would be a thing, and you would show that it works. That's step one, and show that it's safe, right? Bring it to the FDA, run your trials, and then you take that and show it to payers, show the clinical value, and then use existing kind of reimbursement infrastructure. Now, not a lot of that existed historically in digital health, but that playbook still conceptually is the right path, where you not just publish one trial, you just create kind of a publication strategy to show the clinical economic benefit for what your program does across many swaths of different types of people. You show those data to the medical directors who define medical policies at payers and show why this makes sense for them and their members, and then map onto clinical trade wins. And so Omada's future vision and our hope 5-10 years from now is we're just in everybody's medical policy, across the entire country. If someone finds out that they're at high risk for chronic disease, instead of what happens now is you get handed a pamphlet and you're told, go lose weight.
Good luck.
You're routed into a program.
Yeah. So how much effort did it take to convince some of the chief medical officers? Because you're right in that transition now with Medicare and potentially even private payer, right? Private
Well,
insurance.
I would say even private, it's happening even quicker maybe in the public.
But how challenging was that?
It's really hard.
Chief medical officers are not easy people with their actuaries, and they say, great, it works for African American females, but it's not going to show me that it works in
show me your 65 plus data.
Right.
Yeah. So you have. It's very, very hard. There's no. I think enterprise healthcare is just hard. It's. I was talking about it's kind of like the black diamond of entrepreneurship. You use capital intensive. There's no. There's no shortcuts. I remember early on. You find these inspiring medical directors that are so passionate about the clinical problem. And I remember we're like 10 people at Omada, and I'm sitting across from this wonderful medical director who wants to make this happen. He's looking me in the eyes, and he's like, Sean, I'm writing you into a contract that's 5 years, right? You're a startup, you're 10 people. What gives me confidence that you'll be here 5 years from now? And what you want to say to him is, if you sign this contract, that really helps secure. It's like, you're kind of in the driver's seat more than you think here. You can't say that. So, what do? So you just roll the boulder, like never give up, right? And bit by bit it just happens. You publish more studies, you get referenceable customers, you just figure out how to do the claims billing, and then there is this moment which enterprise healthcare companies get to where you're slightly more de-risked.
Yeah.
It's a very risk-averse buying market, appropriately so, but then you get past this, and you've worked in ASO populations, exchange populations, fully insured populations, HMOs. You've done provider referrals. You've done all swaths of demographics, and you start to build cadence. But it does not come easily, nor should it in healthcare.
So we got a couple minutes here. I'm not going to ask an audience question, so let me take the opportunity. So now you've proven that it works and it's scalable, which was one of our original concerns. We didn't invest in
Series A. He passed on our Series A.
And we're still friends. So. But I got to invest at a much higher price, which is good for Sean. What about competitors, right? Back to this question of gosh, you guys have done a ton of work, you can show engagement, and now there are a bunch of people coming along, maybe it's Weight Watchers or somebody else, or people actually saying, I can do this with bots, I can do this with just sending people a scale. How do you think about the competitive dynamic and why this is a defensible business?
Well, yeah, so clinical data is table stakes, right? It's very hard to gain a ton of commercial traction in our space unless you have at least a year-long, data, publication. At this point we have 6 peer-reviewed publications. We probably have six coming out this year alone. And many more, coming. Our chief medical officer, we should just announce this, but is the former global chief medical officer of Sanofi, is our CMO designing our clinical trial program. And so it becomes data's table stakes, but also data becomes defensibility because you really have to garner trust with the clinical audience, and the more evidence you show, the better that becomes. And I don't think we'll ever get to a point where we're fully proven, because there'll always be questions.
Yeah.
Oh, well, what about that population or this, et cetera. So that's one bit. The second is our pricing model. When you're doing performance-based pricing, you win contracts because of that, and it's very hard to put up a shingle and a website that looks like what we have or others and say that we do that and charge on a performance-based pricing. You actually have to deliver the result. So I think that business model helps too. And then the last, which I actually think is the most interesting, is just we call it our innovation velocity. And it's through data science, because there are some fundamental realities of behavioral programs that will hold to everyone, yet the next era is personalized prevention, or kind of Netflix for prevention. So we invested pretty heavily in a strong data science team that does all these intricate experiments inside the product, because we launch cohorts every single Sunday, so we have kind of a fresh start to try new things. And we're tailoring and tuning based on demographics in ways you can't even see, you wouldn't even know it. And I think now we have 12 million weight readings, just millions, billions of data points where you tailor and tune quickly, and the more people you enroll, the more quickly you can do that. So when we go out to the market, we talk about that with our potential customers, that they're betting on tomorrow's Omada as much as they are today. And we, through our scale, have this very nice data advantage. We're improving the program at, I think, a quicker clip.
And you're iterating. So iterating like crazy and then figuring out what to automate.
Exactly,
right? Effectively. Great, cool. Thank you so much.
I'm so sorry we're out of time.
Yeah, perfect timing. Thanks, everybody.